Hey everyone, welcome to the Brain Body Reset Podcast. I'm your host, Spencer Zimmerman. Beyond the diagnosis and symptoms, there's a path to feeling better. Dive into the world of brain-body connection and learn how to optimize your health. If you get dizzy, lightheaded, nauseous, weak, or feel like you might pass out when you stand, it is easy for everything to get lumped together as you have POTS. While POTS is one of the most common types of dysautonomia, it is not the only type. We're going to discuss not only POTS, but we're going to look at orthostatic hypotension and neurocardiogenic syncope. While these are all associated with dysautonomia, these actually fit three different patterns of what's known as orthostatic intolerance. Basically, when you make a positional change, how does your body tolerate that positional change? One of these is primarily defined by a drop in blood pressure after you stand. One involves an abnormal neurological reflex that can suddenly drop not only your blood pressure, but your heart rate. While one is also defined by an excessive increase in your heart rate when you make a positional change, without a significant drop in your blood pressure. While the symptoms between these look very similar, at the underlying issue with what's actually happening in the body, it's going to be a little bit different. And because of what's happening, there's not one defined treatment, especially when we're looking at medications that should be given to every single person. By the end of this video, you should understand what should normally happen when you stand up and you make a positional change, how to tell these three apart, also understand how they're commonly treated, and why getting the diagnosis is only the beginning. So what should happen when you stand up? So we're looking at a graphic here that starts with someone laying down and then they stand. One of the very first things you see is when you stand, you're going to get venous pulling. So what's happening with the blood volume? Well, instead of it being evenly distributed, you're going to get a massive rush of blood volume down to your legs and your abdomen compared to your chest and your brain. This can actually be upwards of 1 liter of blood that can make that transition. Now, what happens next? Well, the amount of blood volume here goes down. So if what's returning back up through your veins to your heart is less, you have less getting back to your heart. And as a result of less getting back to your heart, the amount of blood that gets pumped from your heart is going to go down. This is your stroke volume, is what gets pumped in each and every contraction. And if you have less in every contraction, your ultimate cardiac output is down. But you have counter-regulatory measures that is meant to help you be okay. One of these that they list is called a baroreflex. So you've got all these baroreceptors in your arteries, and it senses pressure. So when there's a lot of pressure, it's feeding information in the brain, everything's happy and healthy. When the pressure goes down, there's not as much input going to the brain. And the brain fires down and says, hey, I need you to constrict all the blood vessels, muscles, I need you to activate a little bit more to get all the blood flow and oxygenation back to the brain so things are happy and healthy. And this is a very temporary thing, okay? So it is normal if your blood pressure goes up 5 points. It is normal if your heart rate goes up 5 to 10 beats per minute. But this is a very transient thing. So this is not a 2 minutes down the road, it is still happening. This is something where for many people it's common. If you make a positional change, you stand up, you may be lightheaded for like 3 seconds and then you are okay. Now, it's not just the neurological reflex per se, it's also how the neurological reflex also tells the kidneys and other things to help support blood and fluid volume. So it's important to understand that your body is coordinating your brain, and then the brain, right, fires down through different nerves. So you've got autonomic nerves helping impact the blood vessels, heart, muscles, kidneys, hormones, and keep your blood volume where it should be, which is in circulation, and prevents it from going in to the interstitial spaces when you stand. And you should not have to think about this, right? This is all automatic. Now, why these are all underneath the category of dysautonomia is dysautonomia means that your autonomic regulation is not working the way it should. But how this is occurring is going to be different. Now, one of the very first things, though, before you go into dysautonomia, is you need to say, is there a better explanation for this? So orthostatic intolerance, once again, means you develop symptoms while upright that improve when you lie down. The variety of symptoms may include dizziness, blurred vision, brain fog, nausea, palpitations, weakness, or feeling like you might pass out. But having orthostatic intolerance does not mean this is always a neurological issue. And this is one of the reasons why people are frequently told you need to go and see a cardiologist, because we need to make sure that things are rolled out. So what's a cardiologist going to do? They're normally going to do an ECG or EKG, depending on where you live in the world. We'll call it different. They're going to do a heart evaluation. They may do a structural evaluation, known as an echocardiogram, to look at what's happening, right? Do you have heart failure? Do you have issues with the size of your heart? Do you have a valve issue? Do you have things in that arena? They also may have you do 24, 72, or even some people, they're going to have you do heart monitoring for a total of 2 weeks, known with like a Zeo patch, to say, is there a better explanation there? They'll bring you through testing. They may have you do a orthostatic testing where you're just laying down and then standing up, but they may also have you do a tilt table test. And beyond a tilt table test, they may even have some people do a stress test to see what's happening as well. Because once again, there's a lot of different things, and we'll go into more of these in a moment. But even in the heart world, if your explanation for orthostatic intolerance is your heart, that is where you need to be for help. And so it's okay to have it done. And this is something that's frustrating for a lot of individuals, though, because you get sent to cardiology, they tell you things are normal, and the reality is, for the average patient we see who's been diagnosed with POTS, whether it came from long COVID, other infections, vaccines, after a concussion, Ehlers-Danlos, or related to mast cell activation syndrome, your testing is going to be routinely normal, and they're not going to find stuff when they look at the heart structure. Now, that does not mean that the cardiac evaluation was completely worthless and unnecessary. But what it does mean is that we know there's not certain pathology at play, and we can shift our focus to other things that may be at play, such as your nervous system, with confidence. Because there's nothing worse than going down a path hoping it's going to help you, and you skip some fundamental steps that you should have looked at. Now, when we look at other things beyond the heart, don't miss, some of the easy stuff, right? You've got dehydration, you have anemia, you've got whether that anemia is B vitamin or iron. You can have an acute infection. And this is one of the reasons why when we're looking at these diagnoses, we're not diagnosing it because it happens once. We're looking for a consistent pattern. And you'll see here, you can have coagulation issues, you can have COPD, you can have chronic kidney disease, you can have neurological stuff, stroke, dementia, you can have trauma, so concussions or severe traumatic brain injury. Every single one of these can play a role. You may have adrenal insufficiency, so if you look at your cortisol level, it's in the toilet, it just doesn't really exist. Hypothyroidism is also known to play a role. People have got malabsorption syndromes. Pregnancy can even cause it transiently. Now, it can also develop after pregnancy and be more persistent, and that does need to be treated. But even with pregnancy, some people are more prone to orthostatic hypotension. You can have even the effects of medications, which we're going to get to in a moment. So as you can see, right, there's a lot of things that should be looked at, that should be considered. So you can have, once again, orthostatic symptoms because the nervous system's not able to do its job properly, but you can also have appropriate autonomic function, but unfortunately, it's making up for this other stuff. Okay, so we need to know when the nervous system is doing its job right and it's making up for other issues versus when the nervous system is not able to just do its job right. because both of these can happen. Now, I do want to go into medications because so many of you have been put on medications, but then others of you are already on meds. So there's a wide variety of medications that can cause lightheadedness, dizziness, and other orthostatic intolerance related symptoms. This may include diuretics, okay? You may have different medications like clonidine, or you have a lot of heart medications, whether it's amlodipine as a calcium channel blocker, metoprolol, propranolol as beta blockers, even erectile dysfunction meds. You have antidepressants such as amitriptyline, nortriptyline, antipsychotics, trazodone, which we'll come back to, and then medications that even are used for Parkinson's disease. Now, I do want to say something about propranolol and metoprolol because a lot of you are like, oh my gosh, I've been prescribed it. Did my doctor give this to me? We need to look at the time sequence of what happened. So if you were not on those medications and they're evaluating you for POTS or another type of dysautonomia and your heart rate's going crazy and they put you on the medication, then we're not going to blame the medication for your orthostatic intolerance. But there are plenty of you who have been on 3 to 5 of these medications all at once. And if that's the case, then that should be evaluated as a reason for having the orthostatic intolerance, because one's a medication-induced issue versus not. Now, trazodone, want to come back to that. What is trazodone commonly used for? Well, it's used for an issue that many of you have. That's going to be sleep. And it's routinely used off-label for sleep, partly because, one, it works pretty decent. 2, it's also a cheap medication. So while trazodone can help with sleep, there is research that does show trazodone as an issue, right? So similarly, trazodone is a potent alpha blocker that can worsen orthostatic hypotension. Also shows us tizanidine. This is a muscle relaxant, which can also do it. Carvedilol, okay? This also can do it. And so here's the stuff for erectile dysfunction. So we do see there are a variety of things and medications that people can be put on that can contribute to it. And this is why it's really important to make sure any provider you're working with knows what medications you're on, even if they didn't prescribe it, because it's about getting a complete picture. One of the things that we're not going to spend a lot of time on, but we're going to briefly cover, is going to be the neurodegenerative causes. So you have neurogenic orthostatic hypotension, and this can occur with a variety of neurodegenerative conditions such as Parkinson's disease, multiple systems atrophy, pure autonomic failure, diabetic autonomic neuropathy, Guillain-Barré, and more. These conditions do matter and they should absolutely be treated. But you're also going to see other things, right? Parkinson's disease, you're usually going to see the tremor, you're going to see the changes in gait, stability, and all of that. You're not going to just see orthostatic hypotension on its own. And it's important to understand that while these things are there and they do exist, this is going to be a smaller group compared to those of you dealing with orthostatic hypotension, especially when we start looking at younger. We look at teenagers, young adults, middle-aged adults, really anyone under the age of about 60. For most of you, this is not really at play. You will have POTS, orthostatic hypotension, neurocardiogenic syncope, whether it's related to a virus, an exposure, concussion, it doesn't matter. That's where most of it's going to be. Now, when we look at orthostatic intolerance, there are a wide variety of things that can play a role in this. So we've got the different types that we already talked about, right? We've got orthostatic hypotension, we've got neurocardiogenic syncope, we have POTS, which goes through here. Now, just really quick before we go into each one, orthostatic hypotension, what are we going to see? Well, we're going to see someone who stands up and their blood pressure goes down pretty fast. Okay, so this is going to be the very classical orthostatic hypotension. You stand up, it comes down very, very fast, greater than 20 for systolic or 10 for diastolic, and then it stays down. This is the classical orthostatic hypotension. Versus you stand up, your blood pressure's okay, or it doesn't go down significantly, but your heart rate goes way north. This is going to be POTS. And the neurocardiogenic syncope doesn't truly have a time sequence. What's going to happen with the neurocardiogenic syncope is that you are going to stand up, and at some point of being on your feet, your heart rate and your blood pressure are both going to tank. And this is the only one where you will faint. POTS, orthostatic hypotension, while you can faint, it is not always required.
If you're finding this information valuable, please share this podcast with others and give us a 5-star review, as that is the only way this podcast grows. Please continue listening and keep enjoying.
So once again, remember, these do overlap. You can technically have both POTS and orthostatic hypotension, or POTS and neurocardiogenic syncope. But the time frame of when this happens in the testing gives us a lot of good information about what's going on. So let's dive in now to orthostatic hypotension. So once again, let's go back to that initial chart that we looked at. So classical orthostatic hypotension, once again, is generally defined as a sustained reduction of drop in blood pressure of greater than 20/10 within the first 3 minutes of a tilt table test or a laying to standing test. Now, it's important that it is preferred to do laying to standing, because if you go from laying to sitting to standing, you can actually give a false response to this. Now, remember, what should happen when you stand, you're in a temporary drop, but your system is going to rebound. And this is why even when we measure, we're measuring people's vitals every minute to say, is it sustained or was it very temporarily? If it's temporarily, okay. It's okay. And then as we learn here, right, you can have the initial orthostatic hypotension and you rebound and you're okay. You can have the classical, where it stays low. On the other side, you can have a delayed response. So your blood pressure may actually be okay for at least 3 minutes, and then it drops. So where you have the delayed, this is where you can actually have orthostatic hypotension plus POTS. But unless you have a delayed, you can't. So like you cannot have a classical orthostatic hypotension with an increase in heart rate and say, I have POTS if it happens immediately. Because what's happening from a heart rate perspective is just purely compensatory for the drop in blood pressure. So the timing of what happens with the blood pressure is absolutely essential. Now, there's a lot of different reasons why people can have orthostatic hypotension. As we've talked about many of the other things, it can be neurological, it can be autoimmune, so you can have like a small fiber neuropathy. You can also just have things where your system is struggling, like people who are dehydrated. You've got blood volume loss, right? You may have it around the time of your menstrual cycles, but no other time because you're going anemic. You may have it with medications. And orthostatic hypotension, you know, it's much more common than people think, right? Orthostatic hypotension, a common, often overlooked disorder with many causes. It is associated with many different symptoms. Some people are falling, they've got syncope, they've got cognitive impairment. And then you can even have this chronically, once again, as a result of a variety of things: autoimmune disease, diabetes, hypertension, heart failure, kidneys. There's post-infectious, and so much more than that. And this is why it's important that everything is taken as part of a bigger evaluation. Because when you're trying to find answers, as we've already reviewed many of the things that can contribute to this, those need to be evaluated and dealt with. And when those are not there, that's when you can start looking at research papers like this, where they say not only, hey, here's the evaluation, here's what's happening, they do talk about what are some of the non-pharmacological treatments. Now, one of the things they do say here that's super important is we advocate for an individual approach. What is going to best work for one person may not work best for someone else. So please review medications. There's also a lot of positions that people will use. How many of you find yourself crossing your legs, putting your legs up on that, bending down like that, crossing it like that, right? These are all things that, as you can see, impact blood pressure changes to an extent. And people are like, why are they doing that? Well, it's because they're trying to make sure enough blood flow is getting back to where it needs to go, to be honest, so they won't feel bad. Many people are told they need to drink a lot more water. Some people have to eat smaller meals, no alcohol, improve salt intake. And then what's important is don't have physical deconditioning. Now, this isn't saying deconditioning, because in the POTS research, deconditioning isn't believed to be a good explanation for why people develop it. But physical deconditioning can 100% occur as a result of the symptoms. And we do know, when we look at the research, the more people can sustain activity, the less likely they're going to have orthostatic issues. So please try to be as active as you can. They talk about compression stockings, and then they go into all sorts of different medications, which these medications down here are being done. So like when we look at orthostatic hypotension, the only two medications that actually have FDA approval is droxidopa and midodrine. So that's how they're typically going to be prescribed. It tells us about the side effects. I do have lots of people who on midodrine, they do have lots of side effects. Even though fludrocortisone is not a medication that has FDA approval for this diagnosis, it is used quite a bit. So you may have been prescribed it. Acarbose, as you see here, it's used for those who develop hypotension after eating. And then you've got these other ones as well, atomoxetine and pyridostigmine. So there's a lot to it, right? And once again, the focus of treatment, it's not simply just making the blood pressure marker look good. The goal is to improve someone's symptoms, their functionality, and allow them to operate in day-to-day life. Next, let's go into neurocardiogenic syncope. Now, it's important to understand that when we look at neurocardiogenic syncope, it is also called other names, okay? So it may be neurocardiogenic syncope, it may be called vasovagal, it may be called vasopressor, or reflex syncope. So unlike the orthostatic hypotension that we talked about, you may actually be okay for 5, 10, 15, or even 20 minutes when you do testing. But after you've been on your feet long enough, or as you can see in the graphic, after a trigger of some type, your autonomic responses are not able to do their job right. This typically is going to manifest as your blood vessels dilating. As your blood vessels dilate, we know not as much blood flow is going to get back to the heart, so not enough blood is going to be pumped. But it's not just that. You actually get slowing of the heart rate as well. And when the heart rate drops enough, blood pressure drops enough, you're not getting enough blood flow and oxygen in the brain, and people do pass out. So it's actually pretty common with this one where people will pass out. Now, there's a wide variety of reasons this can happen. So here you see neurocardiogenic or vasovagal syncope, panic, fright, too much pain. Someone has a lot of pain, that can absolutely do it. There are people who get it from even sneezing, coughing, bowel movements. So all of those are things that can do it. Now, some of the symptoms that you may have before this occurs is going to be symptoms of the brain not being where it should be with blood flow and oxygen. This could be nausea, you get warm feeling, sweating, palms turning white, tunnel vision, hearing may sound off, weak, yawning, and you may even just be like, hey, I feel like I'm going to faint. Now, while once again orthostatic hypotension can cause a drop in blood pressure, we're usually not seeing the same drop in heart rate. The other thing is orthostatic hypotension is an immediate drop in blood pressure usually, versus neurocardiogenic syncope. Some of these people look completely okay on the test, and this is one of the reasons why people are using, when they do tilt table tests, they're using nitroglycerin and they're stressing out the system to see how it can go. Now, when we look at this, right, neurocardiogenic syncope, as it says, also known as vasovagal syncope, is the most common cause of syncope. So that's passing out, accounting for nearly 1/3 of cases. And even though it's 1/3, it's 66% of cases going to the emergency room. So this is really important to understand that this is a big issue. And now here's an interesting part down here as well is one meta-analysis estimated the global prevalence of neurocardiogenic syncope to be at 16.9% in the general population. So this is much more common than people think, and any passing out is never good because it's not just, hey, I'm passing out innocently onto my bed. It's I'm passing out and whatever surface I'm on is what I'm going to hit. And if I can't spot it, I'm going to fall. I may break something. I may nail my head. There's a lot of people I talk to who've suffered multiple concussions as a result of the neurocardiogenic syncope. And so I don't ever want people to downplay the impact of what their diagnosis is. And this is one of the points of doing this video, is POTS gets all the attention. And so people often feel, well, I have orthostatic hypotension or I have neurocardiogenic syncope. It's not as bad as POTS, when in reality it absolutely is. When we look at the treatment for this, one, it's always going to be about identifying what are the triggers. If you know there's certain triggers, you need to compensate for it. Two, if you notice certain strategies help you. So in the same way with orthostatic hypotension, we talked about fluid, electrolyte, salt, compression. That needs to be done. If you're able to tell when it's happening, lay down, get your legs up. We also showed you the previous pictures on orthostatic hypotension, what people can do from a position with their legs to help them do better. Make sure with your provider there's no medications impacting stuff. So once again, in most people, what's going to happen in the sequence is your blood pressure is going to start falling, and then your heart rate is going to be coming behind it and dropping as well. And this is why some people, when they do the nitroglycerin test, when they do an orthostatic tilt table test, they're going to say, hey, we need to do a pacemaker because we can't have you going beyond a certain point. And then there's also other places doing cardiac ablations, which I'm not a big fan of. I do not like destroying that. Whenever I've listened to other experts, they talk about, remember, it controls the rhythm of the heart. If you destroy it with an ablation, while the research does show passing out does go down tremendously, they are worried about the risk of altered cardiac rhythms that can be 100% deadly because you've completely pulled out the system that should be helping it. Now we're going to go to the one that most people are familiar with, and this is going to be POTS. So POTS is the one that everyone talks about. Now, when we look at POTS from a diagnostic standpoint, it's going to have some very key hallmark stuff. So one, we're typically looking for increase in heart rate of greater than 30 to 40 beats per minute when doing a positional change without a drop in blood pressure. Now, once again, this should include making sure other conditions that could cause it are ruled out. You should have orthostatic blood pressure and heart rate measurements over a 10-minute window. So they say an interval of 2, 5, and 10 minutes. There's other places that will say every minute, but it needs to be done frequently to see what is happening. Now, if you're a teenager, we're looking at an increase of heart rate of greater than 40 beats per minute. Once again, this should occur within the 10 minutes of a tilt table test or a laying to standing test. This needs to be persistent for a period of time. We need to know, as we said, blood pressure cannot drop. So you cannot have classical orthostatic hypotension and have POTS at the same time. So real quick, a heart rate increase of greater than 30 beats per minute on one occasion does not mean you have POTS, because there could be many other things that could explain it. But when it's routinely repeated, this can absolutely do it. And this is why POTS, even though it's becoming more common, it's still probably underdiagnosed compared to what it should be. Actually, I know it is, because a lot of people are making judgments when they look at people and saying like, hey, you don't look sick enough to have POTS, or yes, you do. And there's a wide variety of symptoms with POTS being a heterogeneous issue. You have cardiovascular stuff, you have respiratory, you have gastrointestinal, urinary, musculoskeletal, neurological, immune, endocrine, right? So shortness of breath, nausea, vomiting, diarrhea, muscle weakness, joint pain, neck pain, brain fog, headaches, dizziness, motion sickness, and the list goes on and on. But while there's all of these different symptoms, we still need to better understand what can actually contribute to POTS. So you've got hyperadrenergic POTS, you have what's considered volume dysregulation as a result of the renin-angiotensin-aldosterone system. You can have autoimmune, so ganglionic. You can have neuropathic, mast cell, many other stuff you see down here, chemo, infections. You've got associated disorders, Ehlers-Danlos syndrome, and much more. Here's another graphic. Once again, neuropathic, adrenergic, hypovolemic, autoimmune, norepinephrine transporter deficiency, and mast cell. So, and here's the kicker. You don't need to have just one of these. You can have a combination of these. And this is where it gets frustrating for people, because when you get evaluated, all the focus goes to heart rate. And so, yes, the tachycardia that you have is very real, but it is only the body's attempt to compensate, because if less blood is returning to the heart, and as a result, less blood is getting to the brain is going to tell the heart, I need you to pump faster and faster. Now, there is something we need to distinguish, and this is looking at what could happen with POTS versus tachycardia, because POTS, we're looking for heart rate to go up quite a bit when you make that positional change, whereas IST, okay, idiopathic inappropriate sinus tachycardia, we're looking at heart rate already being elevated greater than 100, even just sitting there or laying down. And then when you get up, it goes even higher. So that would be that diagnosis. And so some of you are actually diagnosed with, orthostatic hypotension plus inappropriate sinus tachycardia. And I wanted to make sure we did cover that. Now, the prevalence of POTS, it's really hard, because when you look at the research, it says that it's going up as a result of COVID and many other things. But when I talk to enough people, it's also likely that this has been significantly underdiagnosed compared to what it really has been for the longest time. And many of the people were just gaslighted, not because providers meant to gaslight them, it's because the providers were just never taught about this because it was considered uncommon and people ignored it. And then just a reminder, when we look at the symptoms of POTS, it is multiple systems that are impacted. So brain fog, fatigue, headache, shortness of breath, tremors, right? Nausea, all of that. And then remember, fainting, while it can happen in POTS, it is absolutely not required and it is not the defining feature. So if someone ever says, well, I don't think you have POTS because you didn't pass out, then that doesn't matter. And here's another one from a long COVID looking at POTS. So you've got the different symptoms to certain parts of the body and then what can happen from a global perspective. And really, once again, when we look at the medications that are done for POTS, it's very similar to what we see with the others. The difference is, right, with neurocardiogenic syncope, right? If people are only passing out and their heart rate's not going fast, you would never use a beta blocker. Or with POTS, you're going to do stuff differently if your heart rate and blood pressure are both going up compared to if it's just the heart rate. Or if there's a change in heart rate with blood pressure going in the opposite direction. And this is why things really need to be defined for the individual and make sure everyone's just getting what they need. And there's not one thing. But once again, between all three, the non-pharmacological stuff really does stay fairly similar. Fluid, salt, electrolytes, compression stockings. Be as active as you can be. Maximize your sleep, improve your nutrition, don't have medication side effects. And with physical exercise being something that is super important, we need to understand, please don't push through it. But there is benefits when you look at the research on resistance training. Okay. Now, remember, because there's some research that's mixed on this. There's some research that says, oh, calf size and calf strength matters. And there's other stuff that says, actually, you know what? It really doesn't matter, and that's the newer stuff. So while it's okay to strengthen your calves or quads and everything else, we're not also reducing it down to that is the only thing you need. And then remember, when we look at medications for POTS, there is no FDA-approved medications for POTS. Yes, some of the ones used in orthostatic hypotension, like midodrine, is being used. Many of you are given propranolol, ivermectin, fludrocortisone, clonidine, guanfacine, and others, and that's okay. But every single one of these is usually done as a trial to see what your response is. And you want to not just improve a vital sign, you want to improve functionality. And this is why, even though you may have the same symptoms as someone else with POTS, but yet if you ask people, hey, what medication worked for you, and then you try it, you may not get the results you want and you're left frustrated. And it's because when we look at the things that can contribute to this, right? We talked about a lot of autoimmune versus sleep versus anemia versus concussion. It's about what that recipe is. And getting individualized, tailored care is absolutely essential. And so as we start wrapping this up, it's important to understand that, once again, POTS, neurocardiogenic syncope, and classical orthostatic hypotension all exist, and they are all not good things to have. You are not allowed to have both POTS and classical orthostatic hypotension. You can have POTS with delayed orthostatic hypotension, so a drop in blood pressure that comes greater than 3 minutes after doing the test. You can absolutely have POTS and neurocardiogenic syncope, or neurocardiogenic syncope and orthostatic hypotension. That is okay. Please make sure medication side effects are rolled out. And once again, fainting does not have to happen when you have POTS. So don't focus on one symptom. Look at everything as a complete picture. The better the picture, the better the results are going to be. Now, for those of you struggling, I want to talk about how I work with individuals and we address this. Because Many times people have done everything they can think of and they're not getting where they want to be. And this is where people get stuck is, I've got these diagnoses, I've done what you want me to do, right, as a result of my blood pressure, heart rate changing, but I'm not getting the outcome that I want. And this is where we have to shift our framework, because what's your heart rate and blood pressure, it does not necessarily tell you why your nervous system cannot regulate you being on your feet, why it can't keep your blood pressure as good as it should be, why it can't get enough blood flow to your brain. Now, many of the things you've been recommended are not inherently bad ideas. Medications, salt, electrolytes, fluids, all the specialty evaluations, okay? But most of these are compensations, because if you stop them, everything gets undone. We've got to say, what is driving that? And that's where, once again, we look at the patterns. What's happening with your heart rate? What's happening with your blood pressure? But what's happening not only with the vitals, but what's happening in your symptom patterns? Menstrual cycle, sleep, stress, foods you're eating, getting sick frequently. How does all this stuff play a role? We're also going to look at what's happening with your nervous system, because guess what? Your autonomic nervous system, which all these fall underneath, is part of a bigger nervous system. And what's not talked about near as much is that your brain actually regulates this, and it does it through a variety of mechanisms in your brainstem, your vestibular system, which is responsible for how you orientate yourself with gravity, which is exactly what orthostatic hypotension is, your visual system, movement patterns, Ehlers-Danlos, all of that stuff can impact this. And so we're doing detailed neurological examinations. We're doing eye movement testing, balance testing, vestibular testing, cervical spine testing. We're going to look at all that to say what's adding up for you. And then remember, what's happening in the brain does not exist in isolation. So if you have co-occurring anemia, whether it's iron or B vitamin, blood sugar issues, hormonal issues, gut, mast cell, sleep, it doesn't matter. Those need to be taken into a bigger picture as well. And then with all this information, the key is to say, what do you need to get better? Let's target a plan based on it for you. And this is where a lot of people say, but how would you treat this? My answer is always, what does the data show us? I can lay out a framework, but I have nearly 30 minutes worth of eye movements that tells me about a variety of different parts of the brain, and there's going to be an order of importance that I need to address. But what is off for one person is going to vary, and what keeps someone stuck is also going to vary. Like, I've got people who fly in, I've got people who are local people. Half the time I'm like, hey, I can't treat you for 3 to 6 months. We have to lay the foundation before I even address your nervous system. Those who fly in, we have to do it all at once. And then it's important to consider that even when we address the nervous system, the goal is never to force through your symptoms to complete a certain amount of stuff. That does not go well. It is to see how you respond and slowly progress. Because we're not looking for just a change in your heart rate or your blood pressure and seeing how well you do that day. We want to see how it goes over time and how your symptoms are improving. So remember, orthostatic hypotension, neurocardiogenic syncope, and POTS can all make you feel dizzy, weak, foggy, headaches, and feel close to passing out. And while they all do belong to dysautonomia, they are not the same thing, and they have their own defining features. In orthostatic hypotension, blood pressure is going to fall within the first 3 minutes of standing more often than not, even though you can have delayed orthostatic hypotension. Neurocardiogenic syncope, you're normally going to see a drop in blood pressure and then heart rate. In POTS, the heart rate goes up without a significant drop in blood pressure. Getting this important, once again, it does matter, and it really matters for anyone going the medication route, because medications that are appropriate for one person may not be appropriate for somewhere else. So I hope everyone found this information to be very useful. This education is educational and it's not medical advice. Please talk with your medical provider if you have any questions. And if you are looking for extra help and you already have a diagnosis of any type of dysautonomia, but are not sure why you're getting stuck and what could be done, this is what we do and who we help at our clinic, Peak Brain and Body, located in Tampa. Once again, hope you found this useful. Until next time, I'm Dr. Zimmerman. I'm a dual licensed nurse practitioner and doctor of chiropractic.
If you have found the material valuable, please subscribe to my YouTube channel, Dr. Spencer Zimmerman, and leave us a 5-star review on Apple Podcasts or where you normally listen to podcasts from. If you would like to work with me, visit peakbrainandbody.com to learn more. You can find me on YouTube, Instagram, Facebook, or TikTok, all with the handle Dr. Spencer Zimmerman. I'm also on X with the handle Dr. S. Zimmerman 5. This podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other healthcare professional services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials are to be used at the user's own risk. The content on this podcast is not meant to be a substitution for medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition that they have and should seek the assistance of their healthcare professionals for any such conditions.